This is QD Clinic. I'm Jack Cush with Room Now. QD Clinic is brought to you by our coverage of ACR 21. You give us, Room Now, 1, maybe 2 hours of your time, Saturday through Tuesday, and we'll give you the ACR. Today's case, is it RA or is it PSA? So, 47-year-old white female, you've been following for a while. She's seropositive, reasonably high titers of rheumatoid factor and CCP, has RA for about 9 years. For many years was on leflunomide, etanercept did well, lost some control. You changed her from etanercept to adalimumab and was doing well in remission, but all of a sudden starts getting lower extremity plaque-like lesions on her legs. Yes, it's psoriasis. It's over the knees, it's over the legs, it's a little bit, it's around the belly button, it's at the nape of the neck. What is going on here? No family history of psoriasis. She never had psoriasis. She's not on any drugs that induce psoriasis other than the adalimumab. She has a past history of fatty liver disease and hypercholesterolemia. She is not, arthritis-wise is doing well, but wants something for her skin. She refuses steroids. She hates that. She did not do well on methotrexate. The question is, how do you treat her and what does she have? Well, clearly she's got this syndrome of paradoxical psoriasis, meaning that you're giving a TNF inhibitor to treat rheumatoid arthritis, a drug that also treats psoriasis, and paradoxically the patient develops psoriasis. This happens a lot. If you use a lot of TNF inhibitors, you've seen this. The research says it's about 1 per 1,000 patient years. Other collections say it's as high as 2% of your patients that will get this. It can happen in any of your patients with being treated with any TNF inhibitor. Maybe a little bit more frequent with, my opinion, etanercept or adalimumab, but I think that reflects use more than actual risk. It's been reported to occur in RA patients, IBD patients, etc., SPA patients. The interesting thing is the lesions tend to be more frequently the pustular psoriasis variant, either on palms and soles or just pustular lesions, about 50% of them. About 40% are plaque-like psoriasis. And that's really kind of important here because pustular psoriasis as a complication of TNF inhibitor therapy is like pustular psoriasis. It's hard to treat, which means that you probably can't just stop just change the TNF inhibitor or hold it for a while. You have to stop the TNF inhibitor if it's pustular psoriasis. So the majority will improve if you stop the drug. The question is, what can you use otherwise? Good news is in RA, you have many other options, other classes, other mechanism of action that you can employ to control their rheumatoid disease, and they may secondarily treat the skin disease. A third will improve if you continue with another TNF inhibitor, and that's more likely to occur with plaque psoriasis cases, where maybe you can jump around from adalimumab to certolizumab, and maybe you can get away with that. But generally, you're not going to get away with it with plaque palmopustular psoriasis. That's a real problem. This particular patient I followed for many years and required treatment for her RA, but also required concomitant therapy to treat the psoriasis. So along the way, she was on apremilast, on IL-17 inhibitors, and is now on a JAK inhibitor, which interestingly has controlled her RA plus her psoriasis. Not completely. She still gets outbreaks. What's behind this, we don't know. With TNF inhibition, you get a surge in IL-10, and that may drive some of this response. It probably drives the type 1 alpha interferon response, which is seen in these patients. But we don't truly know the mechanisms as to why certain patients will get this and others will not. If we did, maybe we'd have another and better treatment for paradoxical psoriasis. That's it for this edition of QD Clinic. Tune in for more this week.